Good afternoon, everyone. Welcome to IPC Masterclass 6.0 Session 4 on peri and post-operative practices for reducing surgical site infection. We are excited to have Dr. Anup Mohta as a speaker and Dr. Sangeeta Sharma will moderate the session. It's my pleasure to introduce Dr. Sangeeta Sharma ma'am is a speaker, is a professor of neuropsychopharmacology at the Institute of Human Behavior and Allied Sciences and the president of Delhi Society for Promotion of Rational Use of Drugs. She holds an MD in pharmacology and MBA in healthcare administration and certifications in quality leadership from Harvard Medical School. Dr. Sharma has worked in many important roles, including as an technical coordinator for the India WHO Essential Drugs Program and as a medical superintendent. She has conducted over 300 workshops for the healthcare professionals and authorized the Standard Treatment Guidelines 7th edition 2024. She also plays a key role in National Ethics Committee and is the state nodal officer for AMR containment in Delhi. It's an honor to have Dr. Sangeeta ma'am here with us today. Ma'am, I will now hand over the session to you.
Good afternoon. Thank you, Manisha, for a kind introduction, and thanks to SANMED Healthcare to give us the opportunity today to interact with you, all the participants. I think quite a number of participants have already joined, and I have the honor and the pleasure of introducing my longtime colleague, Dr. Anup Mohta. He is a pediatric surgeon, done MS and MCH in pediatric surgery, and he is a fellow of National Academy of Medical Sciences, and he's been very, very active academically. His special areas of concern are pediatric surgery, pediatric oncology, quality in healthcare, and publication ethics. He's a member of active member of ethics committees and other professional bodies, and has more than 160 publications in renowned national and international journals. He has he is holding current position is director professor and former head of the Department of Surgery at Lady Hardinge Medical College and Hospitals, and before that he was director of Chacha Nehru Bal Chikitsalaya. And over there, when he was heading this Chacha Nehru Bal Chikitsalaya, he was very actively involved in developing antimicrobial stewardship. He actively worked on the development of antibiotic policy. Then later on together, I think it's almost 10 years now that we developed these SOPs on infection prevention and control and antibiotic policy for Delhi state. And he was one of very active members in that group developing this IPC SOP and antibiotic policy. So and besides that, as I said earlier, he's been very active academically, lots of publication. He has Journal of Surgery. Before that, he's here and section editor of pediatrics. Both these journals and past chairman of Indian Association of Pediatric Surgeons Delhi chapter, and he's continuing his leadership, research and training efforts, particularly on AMS, are remarkable. So today we have the pleasure of listening to Dr. Anup Mohta, who just not simply talks about the theory, but he has implemented all of these stewardship interventions in practice as well. Over to you, Dr. Anup Mohta.
Thank you, Dr. Sangeeta, and for the kind words. It's been a long association, and with your help and support, we have been able to bring out changes. And I thank you, SANMED, for letting me be a part of this academic feast. And without further ado, I shall share my slides and talk about the okay. So I hope my slides are visible. Thank you. Now today we are going to talk about the peri and the post-operative practices for reduction in the surgical site infections. We'll be mainly considering the evaluation and management of the skin, irrigation, wound cleansing, dressing, and care. So now perioperative care involves so many things, but it's a good idea to focus on a certain aspect and elaborate upon that rather than touching a brief on each topic. I will not be touching about the intraoperative topics of hypothermia and other things like that, but we'll be considering on the skin, which is the major source of SSI occurrence, right? So now, first thing first, it is prudent that if there's established infection at the site of the proposed surgical incision, it should be treated, and the surgery should be deferred till the time that the infection is treated and the patient's skin is fine, right? Obviously, it's practical in a routine case, which is done in a planned manner. However, it may not always be possible in case of emergency surgeries. In addition, not only surgery, even regional anesthesia is contraindicated when the site of the block, local block injection, is infected or is not clean. So it is the importance of the skin condition or the skin health at the time of beginning the case. Coming to the most controversial issue of hair removal or the surgical site preparation. Now, in any patient undergoing any surgical procedure, the recommendation is that hair should either not be removed, or if absolutely necessary, it should only be removed only with a clipper in the theater, right? Shaving is strongly discouraged at all times, whether preoperatively or in the OR. It is my viewpoint that while we are writing the preoperative orders, part preparation should not be a part of it. Part preparation should be left till the end when the patient is there on the table and the surgeon can clean the area, appropriate area and appropriate size and shape, whatever, on the incision, based on the incision, to clean that area with the help of a clipper only on table. Now, surgical site preparation. Now, carefully, we have to wash and clean the skin around the incision site. We all know that. Full body washing with detergent or antiseptics should be performed before the operation. We'll be talking about a little bit in details about it. It is recommended to use an alcohol-based chlorhexidine gluconate solution, usually a 2% chlorhexidine isopropanol for surgical site. Now, what is recommended is, we all know as surgeons that we have to apply the solution using the sterile gauze and instruments, about which our previous talk was there about the instruments, and aseptic techniques. Our movements have to be from the center of the field to the periphery, not vice versa, because by doing that, we invite more infection to come to the surgical site or incision site. After we have applied the cleansing solution, we have to allow it to dry fully because it is alcohol based. We have to allow the alcohol part to evaporate so that there are no chances of mishaps in sort of cautery sparks and all that when the cautery comes in the contact with the alcohol part of it. So we have to ensure that the drapes are not saturated with alcohol or the alcohol-based solution has not formed a pool. Now, what are choices of antiseptics available for skin preparation? Now, there are various recommendations. I'll briefly touch about them. Now, American College of Surgeons recommend that alcohol containing preoperative skin preparatory agents should be used unless contraindication exists. CDC says perform intraoperative skin preparation with an alcohol-based antiseptic agent, again unless contraindicated. WHO categorically recommends alcohol-based antiseptic solution based on chlorhexidine gluconate for surgical site preparation, right? And such Shia says use an alcohol antibiotic. So by and large, most associations or most bodies dealing with infection control recommend an alcohol-based antiseptic, and many of them say use a chlorhexidine gluconate. Some others also recommend povidone iodine, but chlorhexidine based an alcohol solution is the recommended one by the WHO. Now, sometimes the cost becomes more, and if the commercial availability of chlorhexidine and alcohol-based solution is limited or is too expensive for due to resources, the use of 2% chlorhexidine isopropanol solution for skin disinfection can be produced locally according to the formula, and we can have local ingredients mixed in appropriate composition and have a solution for use. Now, alcohol-based chlorhexidine gluconates, they should not be used on neonates or be in contact with mucosa or the eyes. So this is a precaution while we're using these. And they must not be allowed to come in the contact with the brain, meninges, eyes, or middle ear after the surgical site has been opened up. The effectiveness of the using alcohol-based CHD is not proven for pediatric patients, as I mentioned a bit ago. Second point which is recommended or has been used extensively is the use of antimicrobial skin sealants. Now, what are these? These are sterile film-forming cyanoacrylate-based sealants that are commonly used as additional antimicrobial skin preparation after antisepsis and prior to the skin incision. So once you have cleaned it with the chlorhexidine-based alcohol-based solution, we can apply these skin sealants which prevent transmission or movement of the bacteria or the contaminants from the skin to the skin incision site. They are intended to remain in place and block the migration of flora from surrounding skin into the surgical site by dissolving for several days, even post-operatively. However, WHO says antimicrobial sealants should not be used after the surgical site preparation for the purpose of reducing skin. So there's a little controversy, while many associations mention it. So for our purpose, I would say, if you have to stick by this thing, I would say they may be avoided at best. Now, skin wound protector devices are another resource which is available to the surgeons to protect the skin and insert the tissues from the skin flora. So this use of wound protector devices is recommended in clean contaminated and dirty abdominal procedures, but not in the clean surgeries, right? So we have this device here, the double skin. This remains outside. This green one below down remains inside the abdominal cavity, peritoneal cavity, or the wound cavity, and this sheet protects the wound or the organs inside from coming into contact with the skin part. Now, antimicrobial. Yeah. Another point which is useful for surgeons is incisional wound irrigation. Now, there's insufficient evidence to recommend for or against saline irrigation of incisional wounds before closure or purpose of preventing SSI. So it may be left to the surgeon at his preference or her preference, right? So use of irrigation of the incisional wound with an aqueous PVPI solution before closure is used for preventing SSI, particularly in clean and clean contaminated wounds. Now, antibiotics incisional irrigation should not be used. So if at all we have to use a skin wound irrigation, we can use a povidone based solution, and antibiotics are not recommended. Another tool which is available in the hands of surgeons is prophylactic negative pressure wound therapy. Now, there is a recommendation for prophylactic negative pressure wound therapy in adult patients on primarily closed surgical incision in high-risk wounds. That is, I would say, clean, contaminated and dirty wounds, but may not be used in a clean or clean contaminated wounds for the prevention of SSI while taking resources into account. Now, why I'm talking resources? Because these devices are quite costly and they have to be retained in around the wound for quite some time after the surgery, depending on the type of abdominal condition and peritonitis and all that. Now, there is a controversy regarding negative pressure wound therapy with or without irrigation. However, studies have found that there is no significant difference whether you use irrigation or not. So I would err, or I would prefer not to use it. Why add another step? Most important, surgical antibiotic prophylaxis to prevent the SSIs occurring in the wound after surgeries. Now, surgical antibiotic prophylaxis is recommended to be given prior to surgical incision when indicated. It depends on the type of operation we are performing. Now, WHO states administration of SAP within 60 to 120 minutes. If you recall, most other statements talk about giving between 60 minutes of incision. That is because half-life of the antibiotics, generally used antibiotics, falls within that range. However, for fluoroquinolones and vancomycin, because the half-life is different, we can give them within 120 minutes also, because the levels in the blood will remain for a longer time. Now, repeat dose of surgical antibiotic prophylaxis has to be given for longer surgeries, which are there for many hours together, and they cross the T-half of the antibiotic MIC and all that, or when there's a massive blood loss requiring massive blood transfusion. Why? Because once there's a massive blood loss, all the antibiotic which is there in the circulation will be washed out and replaced by the blood which does not have any antibiotics. So we have to repeat dose of the antibiotic for prophylaxis intraoperatively also. Now, preoperative oral antibiotics combined with mechanical bowel preparation should be used to reduce the risk of SSI in adult patients undergoing elective colorectal surgery. What about SAP prolongation? Now, WHO recommends against prolongation of SAP after completion of the operation for the purpose of preventing SSI. At the most, prolonged SAP can be given up to 24 hours, but not beyond that. However, the exception is a cardiac patient where it can be extended till 48 hours. Now, a lot of time we put in a drain and we are concerned that drain will lead to or predispose to infections inside the body. Now, this has not been found to be true, and preoperative antibiotic prophylaxis should not be continued in presence of a wound drain for the purpose of preventing surgical site infections. This is another new kid on the block, you can call it, advanced dressing. Now, every alternate day, the market produces advanced dressings for wound care. Now, standard dressing which we use are the dry absorbent dressing, which consists of the gauze pieces and all that. Now, advanced dressings include hydrocolloid, hydroactive, silver-containing dressings, or polyhexamethylene biguanide, MHB dressings. Now, they are being marketed and they are being used also. However, WHO says do not use any type of advanced dressing over a standard dressing or on a primarily closed surgical wound for purpose of preventing SSI. That means there is no role of advanced dressing in a clean wound, which is after a clean contaminated surgeries which is done, right? Other cases it might be used depending on the type of surgeon. Now, advanced dressing have been in certain studies shown to reduce the risk of SSI in colorectal surgery, but it does not reduce the length of post-op hospital stay or the costs. Okay. A Cochrane review some time back said it is uncertain whether covering surgical wounds healing by primary intention with dressing reduces the risk of SSI, or any particular wound dressing is more effective than others in reducing the risk of SSIs, improving scarring, reducing pain, improving acceptability to patients, or is easier to remove. So this Cochrane review ruled out all the claimed advantages of the specialized dressings or the advanced dressing which are available in the market. Skin preparation we have already talked about in the first seminar of the series, briefly touching upon because it comes in my domain also as an intraoperative thing. Large domain of health care associated infections originate from the patient's own flora that we all know, and that is why we are talking or stressing on the skin management in this session. Now, the aim of the skin preparation is to reduce the microbial load on the patient's skin as much as possible before the incision of the skin barrier. I will not go into details, but we can have a preoperative skin decolonization by preoperative bathing. It's a generally accepted practice as a measure, right? However, evidence to favor a routine use of antimicrobial agent for pre-op bathing is inconclusive. A simple bath with a soap and water is good enough. Now, nasal carriers, we don't know, but if we have a nasal carrier, decolonization with mupirocin ointment with or without chlorhexidine gluconate body wash is recommended in the cases of nasal carriers undergoing surgeries, Staph aureus infection. Okay, this is more important in the case of cardiothoracic and orthopedic surgeries. Wound cleansing. What does it mean? It means removal of surface contaminants, bacteria, and remnants of previous dressings from the wound surface and its surrounding skin. Now, skin preparation and wound cleansing is that is a difference. Skin preparation we talk about, it is regarding the preparation before the wound or incision is made. Now, wound cleansing is after the surgery has been done and we open a post-op dressing. So how do we cleanse the wound or the incision site? We are talking about this. So in addition to removal of surface contaminants, etc., what are the benefits? It allows improved visualization of the wound bed and edges so as to prompt about early diagnosis or early signs of any surgical site infection or complication. It also allows us to remove organic or non-organic material. It removes opportunity. It provides opportunity to remove excess exudate, if any. Now, acute wound requires a surfactant cleanser to remove adherent blood. Sometimes there's active ooze after the surgery, so this cleansing process will help to remove the excess blood from the wound site or which is stuck to the suture line or the staples or the sutures, etc. So we can easily clean them and prevent them from becoming a nidus for any infection there. Now, again, another controversy here, or point of discussion is whether we should perform wound irrigation or wound swabbing, either irrigation or swabbing. Now, irrigation is reportedly supposed to be better because non-traumatic, causes less pain, but swabbing may be required when the irrigation alone is not able to remove the foreign body or biological or non-biological tissue material stuck to the wounds or suture line. How do we choose a wound cleanser? Now, we have to choose according to the type of the wound, whether we are doing it for acute wound or a chronic wound. We have to assess the risk of infection or recurrent infection or current infection. It should have low cytotoxicity to clean the wound, but not high enough to damage the healthy cells. So it should be low, this thing, right? Ease of use and availability should be there. It should have proven clinical efficacy, and obviously it should be cost effective, right? What are the available wound cleansers? They are as simple as that: sterile water, which is not much used, which is used actually, sorry, instead of plain water. Earlier, the plain water was, some people have said plain water is also a cleanser, but since it's not sterile, it's not recommended at all. We can use the sterile normal saline, 0.9%. Sterile water can be used. Polyhexamethylene biguanide can be used, and there are many others, including the povidone iodine antiseptic solution, 10% volume, weight by volume, and chlorhexidine with cetrimide, 0.015% irrigation solution. So these are the various options. You can have your institutional policy and decide what is to be used and what is not to be used. Obviously, the resources also matter. Now, just a brief about the process of wound cleansing. Again, it's an extension of using the antiseptic techniques, right? Aseptic techniques for management of any in any clinical area, right? So we have to prepare the environment and the patient. We have to apply gloves, sterile, and or maybe examination gloves, and remove the dressing. Remove gloves, conduct hand hygiene. Now apply sterile gloves and apply a sterile pack on the wound and commence cleansing the wound or the wound limb wherever we are doing the wound cleansing, right? So we have to, after doing that, we are removing gloves again, conducting hand hygiene again, right? Then cleanse the wound according to the needs of the wound and skill of the healthcare professional. Okay, so you notice that we are using 3 pairs of gloves for each process of wound cleansing. So that's how we don't allow external contaminants and bacteria and all that to come into the wound. So this is the intensity or importance of wound cleansing and the process which has to be followed for wound cleansing. And after this cleansing the wound, we have to apply the new wound dressing and changing the gloves once again. So there's a repeated blood glove changing between each step of wound cleansing. So it may not be cost effective for certain institutions, but a proper method requires this. Now coming to, we said earlier about the Cochrane review, if you remember, which said dressing and no dressing or special dressings have not been shown to reduce SSI, but still we do use dressings. WHO says to reduce SSI risk, it is now generally accepted surgical dressing should be kept undisturbed for a minimum 48 hours after surgery and up to 4 days if possible, unless leakage occurs or symptom changes. Now, what are the symptoms? You could have pain, you could have fever, you could have some discharge from the wound or into the vein, wound dressing would have got soaked. So in those situations, you may have to change the dressing prior to this thing. Otherwise, weather also matters, and the environment in which the patient is there also matters. If it's a general ward, it's not air conditioned, obviously the temperature, humidity and all that may cause moisture and increased propensity to infections. However, in an air conditioned area, the dressing may last for 4 days. So again, the resources and the environment matters. So to summarize to list out the 10 commandments to reduce SSI are, obviously I have not talked about the other factors which I said earlier. I have not talked about hypoglycemia. I have not talked about temperature. I have not talked about a few other things which are topics in itself. So we have to optimize the host risk factors. Secondly, we have to reduce the bioburden on the body. Third is we have to give perioperative antibiotic prophylaxis, as we discussed earlier. We have to have respect for the soft tissues. Again, as a surgeon, I will say Respect to the tissues is one of the most important factors. How we handle it, whether we handle it roughly or we handle them softly and with care, that also affects the incidence of SSIs in surgical wounds. Surgery should be expeditious. It's not a super fast surgery, but reasonably good time, so that because prolonged surgeries predispose to more SSI opportunity for most SSIs. Minimize blood loss, reduce operation theater traffic, which have been covered earlier. Antiseptic irrigation solution has been recommended and be used. Sterilization, the last topic, Madam talked about it. Sterilization of implant instruments has to be immaculate and as per the standard policies. And wound management, we talked about today. In fact, some societies have come out with a 7S bundle talking about the SSIs. One is the safety. When they say, is your operating room safe? Second is, are you screening for the risk factor in presence of MRSA and taking necessary steps? Third is skin preparation. Fourth is shower, the patient showers we talked about. Solutions, are you irrigating the tissues? Sutures. Now another thing which has been recommended by WHO is that you may use antimicrobial impregnated sutures for surgeries. Right? That again, WHO recommends it, and we can use them if available and the resources allow us. And skin closure, which we talked today. To summarize, to prevent SSIs, we cannot overlook sound surgical techniques, hand hygiene practices, and teamwork. Now, teamwork is very important. 1% or 2% of the team follow it, another one misses it, then the whole exercise is defeated. So these three things have to combine together to help reduce surgical site infection in surgical patients. Thank you very much.
Thank you, Dr. Mohta, for explicit, for the explicit, situation or the best practices recommended for pre-surgical preparation of the patient, as well as how do you handle wound. I understand that today was the wound handling part he was talking about. And as you know, that surgical site infections are the most dreaded complications by the surgeons. They don't want to lose their patients because of these surgical site infections. And pre-surgical preparation and this wound handling is the most important. House is now open for the questions. You can write in the Q&A or the chat box. We will take it up. But in my experience, I think that pre-surgical host factor are also important, and the sterilization part. You have already emphasized on the PPE part. The sterilization part is also important.
Yes,
many times, we delegate this responsibility to others, thinking that this will be done properly, but there may be gaps over there as well. So one thing is that you need to do these, follow the sterile technique or the surgical technique that you have, but the autoclaving part, whether the equipment are properly sterilized or not, that is equally important. While we are waiting for the questions from the participants, may I ask you, Dr. Anup Mohta, one very common problem in practice that we see is that if there is a drain put in a patient, many people continue using antibiotics till the time drain is there.
That's what I mentioned, Dr. Sangeeta. I talked in my slides also that drain itself is not an indication for continuing antibiotics. Now, drain can be inserted for two purposes. One is like we do a laparoscopic cholecystectomy and you find us a little problem. So you don't need to, you put in a drain, but antibiotics need not be continued at all. right? But if there's a frank peritonitis in the abdomen and you are expecting some leak or something like that, and peritonitis was there, then antibiotic can be given a little longer as per your antibiotic policy for that surgical procedure. Otherwise, drain alone for a clean procedure or clean contaminated procedure where there is not much as a prophylactic drain where we put in, the antibiotics are not required.
Yeah, exactly. One take-home message should be, why do we need antibiotics? This is at the time of incision. Bacteria occupying the skin flora, they rush inside the body, and if you have enough concentration of antibiotic at the time of incision, that is taken care of. So you don't need post-operative antibiotics. So that is why recommendation is for single dose of antibiotic 60 to 120 minutes before the incision is given. Please mind this word incision is given, because many of the people confuse this with the timing of the operation. They may give it in the ward itself before transferring the patient to the OT complex, and the patient is in waiting over there, and the surgery is done 4 or 5 hours later. So that one dose given in the ward or at the time of entry into the operation be helpful. So please be mindful of the timing, and it is from the incision, not from the shifting of the patient to OT. Okay.
There's few questions here. One is
Yeah.
that what is the antiseptic used in children 1 month or age as chlorhexidine? We can use povidone iodine for preparation and use it safely. Then another is what percent of chlorhexidine can be used for pre-op preparation. I have mentioned in my slides also during the presentation. WHO recommends 2% chlorhexidine solution in alcohol. Next was also we discussed, is it mandatory to give bath with chlorhexidine, gluconate or any soap? Depends on your resources. Generally, a simple soap and water bath suffices for most patients, right? And because resources are also not there, and a good bath, especially concentrating on the area which is to be operated, that will take care of majority of the colonized bacteria and all that. In a rare case, it may be repellent, but that suffices in most cases. But you want to be more sure and resources are there, you can use chlorhexidine-based solutions.
Is there any indication to continue prophylaxis in patients undergoing extensive resection for abdominal malignancy? Guidelines are unclear.
I would not continue antibiotics as being a pediatric surgeon. In fact, I would, although we do give prophylactic antibiotics in Wilms tumors, but once we have done a surgery and there is no spillage or nothing like that is there, I would not give antibiotics, because for me it's a clean surgery, or at the most clean contaminated you can consider, because we dissect out the ureter, right? But that's almost a non-functioning kidney. So and prophylactic antibiotics single dose should be good enough for that if it's possible. But it's not necessary to continue antibiotics for an extensive resection. Depends again on your blood, how your surgical technique has been. Tissue trauma also matters. If there's been extensive trauma and multiple resections and all that, then you may like to continue antibiotics for a longer duration. Dr. Sangeeta
So
is
the take-home message is that you decide antibiotic duration according to the type of surgery, whether it is clean, contaminated or contaminated, and secondly by the duration of the surgery and whether the extent of damage to the that loss. So I think the indication for surgery.
Yeah.
Okay. Good.
So there's another question. How is the compliance of patients in using chlorhexidine bath in your experience? Now, very difficult question. I work in a public sector hospital, so we don't use it much. As I said, for our patients, we recommend a good bath, scrub bath with a simple soap and water. Right? In corporate hospitals, yes, chlorhexidine-based solutions may be used, and Dr. Sangeeta can vouch for that for me. Support me on that.
See, I think, as you said, most of the time, even otherwise, plain soap and water is good enough. If you follow the, proper scrubbing, it depends on the duration, how do you do it? Many times, in my experience, I've seen even, before going for surgery, surgical scrub, people are not doing it properly.
Yeah.
And even for the patient, just bathing with plain soap and water should be good enough.
Actually, what I've seen is going on further. I've seen my friends, and we have also done it many times. Like we do hypospadias surgery or surgery on the testes or the kids and all that. So even though we tell the parents to give bath to the child, sometimes the parents are skeptical कि बच्चे को fever तो नहीं हो जाएगा, he might get fever and all that. So they avoid it or they just do it a superficial bath. So what we do is we cleanse it first with soap and water on the table, then dry him, and then do a skin preparation afterwards. So we are doing the skin preparation on table for the patient in vulnerable areas like perineum and all that. And after that, doing the skin prep with antiseptic solution like chlorhexidine based and all that. So that is what also we do. Yeah.
Okay. Next is advice about clippers in government or resource poor settings.
Very difficult question. Clippers are available now. If you see that two types of clippers can be marketed. They're marketed by 3M. I know about one company. There must be other companies also. So first thing is try avoiding any device to remove hair. For my specialty, is very little requirement because kids don't have hair on the body surface and all that much. So we are safe or easy that way. Only the scalp and all that we require it, the surgeries. Otherwise, you don't need it. But what you can do is use a clipper or you can use a shaving machine, which is much cheaper actually. You have a shaving machine, you can use that, but avoid or use a small scissor to just snip off the hair, which are large to hinder your incision rather than cutting them at the base. You can avoid that, right? So that is what I would say.
I think, it is not a question of resource poor setting or a government sector. It is the question of, what we are used to. We are used to using razor. Even in corporate hospital, even today, I see, before LSCS, delivery, they prepare the part and they use razor.
So that's the issue, as Dr. Sangeeta said, because we write part preparation as a part of pre-operative order. The first order is part preparation before the surgery. Now, part preparation, who will do in the so the
Yes.
if and in every government hospital in the ward now you will see a signboard barber phone number, right? So I go and remove those stickers from my ward, and that's the first thing I do. And before I tell my residents not to call the barber and remove those numbers from there actually, and not write any part preparation for the patient. And if required, we use it in this thing. So resources is not a very costly machine, so you can procure it probably.
Yeah. If we understand why are we saying not to shave, then we will know the alternatives, because we don't want to introduce fresh, abrasions on the skin. What may happen is, one is that the rush of this flora inside the body, or, this may also, the abrasions on the skin may get secondarily infected. So we don't want that kind of interference. That is why razors are big no. And we need to also educate our nurses.
Absolutely.
In some of the places, part preparation is being done by the nurses. I remember this happened in my own family. And when I told the doctor that, we say no for a razor, and why did you prepare? And she had a big flare up of bacterial infection over there. So then she said, oh, I didn't know that the nurses are still doing it. So many times this kind of a communication gap is also there.
Yeah.
Cultures have to be obtained intraoperatively. Should we withhold antibiotics until samples are taken?
No, I don't think so. I don't think so. We have to give the antibiotics. Now, see, cultures. What do you mean by cultures? Well, if there's a peritonitis and you have to take culture, then obviously you are giving therapeutic antibiotics, not prophylactic antibiotic, right? If you are doing on a dirty wound, your patient is already on antibiotics. So prophylactic antibiotics is different, and surgical therapeutic antibiotic is different. So what we are talking about is prophylactic antibiotic. Here we are not talking about therapeutic antibiotics, right, Dr. Sangeeta? I
Yeah,
hope you agree.
yes, on one pretext or the other pretext, we've seen that antibiotics are continued. Single dose is required, but then, one must distinguish between definitive targeted use of antibiotics. Here, if it is generally, if possible, if the patient has not been on antibiotic, it is always better that you draw samples before giving first dose of antibiotic. Generally this is the guideline, but if patient is already
If
on
we are
the
not, what happens is, Dr. Sangeeta, many times we don't expect pus before the surgery. Sometimes you're operating with something and you find a collection inside. So we have not diagnosed it early, so there's no way we can avoid antibiotics preoperatively, no. And if we have a known pyonephrosis, and or a peritonitis, we have already put him on therapeutic antibiotics rather than prophylactic before surgery. So again, that will, and as Dr. Sangeeta said, we should take a try to obtain a sample of the local pus as well as the blood culture simultaneously. For pus culture also, we should have a defined method is there. The 2 samples have to be taken and all that. So that should be followed up, right? Before the cultures are interpreted in a correct way.
If already pus is there, then we have no choice, but we have to take the sample. But when drawing sample from pus, be careful that you don't, if you just collect the pus cells, dead cells, you will not grow anything.
Right.
So many times, we see that frank pus is there, but culture has not grown anything. This is not because of the antibiotic. It is because our collection method was wrong. You should collect, from the edges where the live tissue is there, where you expect these bacteria to be residing. From dead frank pus, you will not grow anything. So please look into the method of collection of pus also here.
There's another question on how frequently do we check for MRSA, and especially in what patients it's mandatory. Actually, in like cardiac patient or orthopedic patient where the implants are being done, there it's much more important because they can have a long-term this thing. Routine surgeries, generally we don't check for MRSAs unless specifically we looking for something. Generally for cardiac and orthopedic patients, they have a routine this thing. Right.
What about a case of prosthetic joint infection? Should we withhold antibiotics until the specimen is taken in the OT?
In the same thing which we said earlier, actually, right? So we have to, depending on the case to case, it matters. Again, if you are suspecting a joint infection, we probably would have started antibiotics prior to surgery, before drainage. So that is what my opinion would be.
Okay. Our next question is about dirty contaminated surgery. Patient comes with oozing wound and fever. Should we include this in surgical site infection?
Okay, now, whenever I'm sure you have heard the word PATOS. Whenever you're assessing a surgical site infection, there's a column for PATOS. PATOS stands for present at the time of surgery. Infection present at time of surgery. So while interpreting the SSI in that case, that PATOS condition has to be noticed and interpreted accordingly. Right? The microbiologist will give a SSI report on the basis of that, what pus was there at that time and what microorganism grown later. They will corroborate and then give you a report of SSI. Right?
Yeah, this brings a very important point about surgical site infections. What do you call? How do you define these? So we must know the definition of the surgical site infection. I was doing one thesis. There they were doing there were 2 groups. One group was receiving single dose antibiotic. The other getting the post-operative antibiotics as was the routine over there. And then in the report, we saw one case of SSI was being reported in the study group where single dose of antibiotic was given. When we looked into the detail, and we found there was a erythema on one stitch only. Erythema on one stitch, perhaps the stitch was too tight, but this patient got piperacillin, tazobactam. Slightest erythema, which could have been relieved by releasing the pressure, by opening up that suture, we treated it with piperacillin. So these are the kinds of things that we see in practice, which should be avoided.
Actually, when the wound comes with infection and all the signs of pus pouring and all that, and whatever, all the suspected cases of SSIs, they are sent, the samples and the forms in the prescribed format, details are sent to the microbiologist. They decide on the organism and growth and all that. Then they are generally, they discuss with the clinicians. And then they say that it's a clinical infection or a SSI. The difference between the two must go into definitions. I think that is beyond the discussion scope today, because SSI definition and all that is a totally one session chapter. So we can discuss it some other time and some other occasion, but you can have a discussion with your microbiologist and talk about it, right?
That's very right. Very right. One thing more about wound handling, I can share my experience here. Many times you've seen, you said you have to change gloves 3 times during wound handling. Many a times, again, we have seen that this task is delegated to someone else who is not very well trained to do this. Or nurses, who are not following these aseptic precautions about this. And even worse that we have seen is, people wear one glove and then they do multiple dressing one after the other with the same glove. These are the things that are responsible for infection, and we try to fix all of these by extending the duration of antibiotics. I think one of the objective of today's session was how can we optimize the use of antibiotics to prevent this surgical site infections. And I think other than this surgical procedure, other factors, host factors, the preparations, the wound handling are more important. And if we focus on these 3 aspects, we can cut down a lot of antibiotics that are being fed to these patients. I hope Dr. will be agreeing.
That's what I summarized, Dr. Sangeeta, in the 10 commandments and the 7S. And the last slide was that only, that hand hygiene is most important, respect for tissue is second, and teamwork is there. If the team doesn't work in synchronized manner, one breach can cause havoc. So that is there. So
many times the patients are, stitches are removed. We ask the patient to come to OPD for stitch removal, and then a dresser over there in the outpatient department has no idea at all about this wound. He may not even have enough supplies, sterile supplies. So kindly look into these aspects. These are, I think, more important than the antibiotic part being, where we are focusing all our efforts on antibiotic. They will not help the patient if we are not following hygiene, sterilization, and all those aseptic techniques.
So we generally tend to blame the system for this, but we are the system. We make the system, right? So we have to individually, all of us have to bring about a change in a cohesive manner, right? Right at top administration to the lowermost category staff, healthcare professional, they all have to work together. And nobody can say, like quality, nobody can say SSI is not my cup of tea. Other people can take care of it. So it's been a wonderful discussion here. Anything else you would like to ask?
Sir, we have some poll questions. Audience, you can answer these poll questions. I'm launching the first poll question. Yes.
Manisha, I don't see poll question on my screen.
Ma'am, you can go near the left side, polls, or the bottom you can see the
In the
polls.
bottom is a poll, ma'am. There are three bars coming there, no? That's
Okay,
a poll.
okay, got it.
There was another question in the question after surgery, when should we open the wound? Generally, we would not open it for 48 hours at least. And I mentioned in my presentation also, you can go up to 4 days, 3 to 4 days in a clean cases. But if there are any signs of infection or pain, etc., you can open it earlier. So you can go up to 2 to 4 days, absolutely. And depending on the weather itself, sir.
Yes,
It's,
sir. I'm
yeah.
launching the results, sir, for the first question.
Okay, yeah.
What time the part preparation for surgical site performed? At home, at the pre-anesthetic checkup, at the pre-operative room, on operating table?
I think the answer would be D. On the operating table, clipping should be done on the table rather than in this thing. So I think there's a difference of opinion here, right? So we would do it on the table. That's what I said. This should be the last thing, because even 2 hours in the pre-operative, the patient stays in the pre-op room for 2 hours after preparation. We are predisposing to the wound infection or colonization, right? So it should be done on the table itself, right? Yep.
I'm launching the second question. Yes. Everyone can answer your poll.
Wow, 100%. Yeah. Beginning of the voting.
अभी सबने वोट नहीं किया है.
They're still voting, yeah.
Yes. It's not changing. So good.
No, there's a difference of opinion. Yeah.
Still voting.
Okay, sir. I'm publishing the result. Yes.
Yeah. I think the majority is right. 83% alcohol-based fluoroxygen gluconate is the recommended by WHO for skin preparation.
Yes. Yes. Third.
Oh.
Why should obesity?
It's just an option. More fat, more this thing. It's a distractor.
Now you've given the hint also.
No, it's fine. It's all right. Most of them are right here.
And it is 54% only.
Yeah. So it's a tough fight here.
Sepsis is a close confounder here.
Yeah. Sepsis is a close confounder. And people have opted for obesity also.
Okay, sir. I'm publishing the result.
Yeah. So the answer is D, massive intraoperative blood transfusion, which is mandated because of massive blood loss. I clarified in the talk that if there's a massive blood loss, the blood, the antibiotic, the circulating blood volume is lost. So you have to repeat the dose to load the patient's blood again in case of massive blood transfusion has been given. Right? So that's the answer. Thank you.
Thank you,
Dr. Mohta, for such a lucid talk on how to prevent infections post-surgical.
Thank you.
I think we have covered all the questions as well.
Yes.
Yeah, thank you. Manisha, you can take over now.
Thank you, sir. Thank you, ma'am, for the wonderful section. And it was a very good session and very interactive. And we have answered like every question which was asked by the attendees. Thank you very much for your valuable time.
Thank you
And
very much.
thank
Thank you,
you.
SANMED, again for the opportunity. Thank you, Dr. Sangeeta.
Okay, bye.
Yeah, bye.
Thank you. Thank you, everyone.
Bye.